Okay, so if we actually crank that back up and go up to here, we have the common fibular. So if common splits into the superficial fibular and one other, what is the other? The deep, right? So deep fibular. So logic can help you at times. If there's a superficial, there's probably a deep. So what is the deep? Where does it go? What compartment?
Front compartment. No, it's
posterior. Wait, no, posterior.
I don't know. False.
Which compartment does it look like it's going into?
It looks like front. No, posterior. For sure, posterior. Final answer.
Which view of the leg is this? Anterior. So anterior compartment sits right through here. The deep perineal, the deep fibular nerve goes into the anterior compartment, which means that it goes to which muscles, or which muscles are innervated by this nerve, by the deep perineal. Tibialis anterior. Peroneus tertius, which is the one all of you are going to forget on your exam. What other two?
Peroneus longus?
Extensor hallucis and extensor digitorum longus. Extensor hallucis longus, extensor hallucis longus, extensor digitorum longus. That's all anterior. There's 4 in the interior.
What was the first one? Tibialis anterior.
Tibialis anterior.
Peroneus tertius. Extensor hallucis. Making sure you guys.
Alright, if we go posterior.
The first one.
So, superficial compartment. Posterior superficial. What muscle group is this? Triceps surae. S-U-R-A-E. There are 3 muscles, hence them being called triceps. Gastrocnemius, soleus, and plantaris. So, plantaris, gastrocnemius, plantaris, gastroc, medial and lateral heads, and then hiding underneath is our soleus. And what do you know if we go and highlight that nerve? Getting on my nerves, man. Oh, that's my cutaneous. Now recognize something real quick. We've got this nerve right here. This is our common fibular. It wraps around the fibular head. So if you take a trauma to the lateral lower leg, below the knee, on the fibular head, you can have damage or palsy. If you're going to end up putting an ice bag on somebody for an injury, for a muscle, for the bone, muscle, whatever, that's so superficial that you need to check and make sure that you're not doing too much cold to that area. Because anytime you have very superficial nerves, you've got the capacity to piss off the nerves. And they don't like to be pissed off.
Right. Can that be regulated with just time? Like, no more than a few minutes of icing? Or would it still damage?
Be mindful of what you're trying to ice, and so if you're trying to get it higher than that, maybe try to get it above the fibular head potentially. I wouldn't have it on there for, I mean, your 15 to 20 is fairly standard, but check to see if they've got a hypersensitivity or if they have an issue. If you take the ice bag off, they've got numbness, tingling, weakness, whatever,
Okay.
then presume that's an issue and then find a way to deal with it in the future. Either put a layer on there or ice them in a different way. But recognize that it's there, which can be problematic. So, gastroc, plantaris, and soleus, right? What is the origination of the gastroc?
Epicondyle?
So they're coming up from the condyles, right? From the epicondyles on the medial and lateral aspect. What's the origination of the soleus?
Soleal line.
Soleal line on the tibia. It makes it pretty darn simple to remember. Now it does cut across to the fibula as well, but you know we can forgive it for that. So, soleal line on the tibia will get you anything you need in life and more. Screw home mechanism. Explain it to me.
The popliteus.
The popliteus muscle unlocks it, which is that happy little band right there. We've actually got an athlete here who's avulsed his popliteus muscle.
Damn.
I've never seen it in a lit. I've seen a strained one on a soccer player before, and I've done rehab with that, but I've definitely never seen one avulsed. So that would be an unfortunate, unhappy day. I think he did his ACL and his popliteus muscle somehow.
How do you do that?
Plant until he rotate is my guess for the mechanism for the ACL, and there's enough rotation that he managed to grab his popliteus. Yeah.
The nerve for the posterior
The tibial. So we've got, up here we've got our sciatic nerve. Above the popliteal space, that sciatic is going to split into tibial. Oh, sorry, there it is. That one right there. So above the popliteal space, if I go and hide that guy out of the way, we'll see how the sciatic nerve here has the common peroneal branch off early before the popliteal space, then my tibial nerve comes down below and goes down straight through into both. It's going to innervate both the posterior superficial and posterior deep compartments. So once again, if you can learn the pathway of the nerve, then you don't have to memorize the individual nerve innervation, individual muscle innervation for each muscle. So make your life easier, try to compartmentalize things. And there's popliteus. Good, so deep. Deep, posterior deep compartment. What do we have in it? What's left? Tibialis posterior.
Flexor,
Flexor hallucis longus.
Flexor.
Flexor digitorum longus. All innervated by the tibial nerve. Posterior tibial artery, if you want to go that far. Anterior tibial artery goes into the anterior compartment. So why do we care? Why do I beat into the compartments of the lower leg?
The posterior compartment?
So if I were to take cleats and go and just kick you clean off into your anterior compartment, just a nice quick shot right into your tibialis anterior, when you're not wearing heavy shin guards. I'm a bad soccer player and I just toe punched you right in the shin.
Don't punch you.
Toe punch. Toe punches are bad. No toe punches. Okay, so what is that going to do? What are we concerned about? Compartment syndrome, acute compartment syndrome. So what is the concern with acute compartment syndrome?
Swelling the fascia doesn't stretch.
The fascia doesn't stretch, and so we don't have a lot of space for this swelling to go. So what are the signs and symptoms that we're going to see with this?
extreme
Pain, it's not going to feel good.
Stop foot.
What's that? Swelling is going to start, and it's going to increase over time.
Just more like information.
Loss of function, how?
Distally.
Drop foot. Good. Tingling, numbness, drop foot. What's the drop foot coming from?
Nerve. Or loss
Okay,
of
but what's preventing the strength?
the
tibialis anterior not being able to
Well, your-
extensors.
that's flex, yeah.
tibialis anterior not being able to
Why can't the tibialis anterior
fire off
fire?
Nerve damage.
pressure off.
Compartment.
You'll see it before you have enough pressure to have nerve involvement. So what's the root cause of having weakness?
Muscle
The
tension.
drop foot is a weakness and an inability to pick up the foot. So what is it that's causing an inability to contract the tibialis anterior to pick the foot up?
Compression of the nerve.
Nope.
I just tried that already.
So tibialis.
So what else is going on? How do muscles contract?
Firing of nerves. Blood.
I mean, when the Hulk goes and gets mad, he's a little guy like me, and all of a sudden he gets real big, and he flexes and he blows out his shirt, right?
There's no room.
But he never blows off his pants. He's got no glute strength at all. It's tragic. Patella femoral, I bet, is bad with that dude. So what we've got is we have the sliding filament theory. We know how. Oh, don't you shut off. So when you contract, muscles slide over each other. They take more space. You flex and you have a bulge. If I go and put a lot of swelling into that space, you have no space for that You said nerve something or other, and then.
So it's just general compression, right? Is why you can't.
Well, the swelling is going to prevent there from being any space for that sliding and that